Hello and welcome to the MiCare Champion Cast. I'm your host, Brian Peters, CEO of the Michigan Health and Hospital Association, and today I'm honored to have our newest MHA board chair, Dr. Julie Yaroch, joining me here in studio. Dr. Yaroch is president of ProMedica Charles and Virginia Hickman Hospital, a mission-driven nonprofit health system serving Northwest Ohio and Southeast Michigan. In today's episode, we'll learn more about Dr. Yaroch's journey to healthcare and what priorities are top of mind as we kick off a brand new MHA program year. Julie, thank you so much for being here and welcome back to the show.
Brian, thank you for having me. It's an honor to be here.
Well, this is not Julie's first time, and she has joined us on the MiCare Champion Cast in the past to talk about some very important issues. But as we've done before, we really want to hear your story, Julie, because we may have new listeners, and I think it's always appropriate to hear how our guests came to be in the position that they're in today, especially now as we're lifting up healthcare as a career option for our young people. So, telling our story, that's been a theme of the MHA. Can you tell us your story?
Yeah, so I started out as a vet student. That didn't go very well for me. I tried to adopt pretty much every animal and quickly filled up my parents' basement. So like most people in healthcare, there's some event in our life that was impactful that made us want to go in a career path. And for me, it was an injury that I incurred that maybe could have gone a little bit better. And so wanting to be part of the solution, I pivoted away from caring for animals to how can I care for people? And that led me into med school. And I will say med school was, we don't remember a lot of med school because it's long hours, but I was hooked quickly. It's absolutely a fascinating field to be in. From the first time that you have a patient that's flatlined, that you resuscitate, and then you get to follow up the next day in the room and see the family around them and they're talking, and without your intervention, they wouldn't be here anymore in this world. Or you get to put your hands around a heart that's beating for a transplant patient. Or you're holding the hand of someone who's at the end of their journey in life and you bring dignity to that. Those are just emotions that I can't describe. But I think that's what hooks most of us in healthcare. We want to bring solutions. We want to improve healthcare in our communities, build healthier communities. So I started in med school. I changed, like many students do, from orthopedic surgery to general surgery to finally chose internal medicine. And quickly on, even though I'm from Chicago, I have several family members that are in rural environments listening to some of the inequities that they experienced being in more isolated or remote areas. I wanted to do something about that. And knew later in my career that I wanted to spend most of my time in rural health. I wanted to be that traditional internist that did it all, put in central lines, intubated patients, did outpatient work, inpatient work, and even some long-term care. So went into internal medicine, and shortly in my career, about 3 years in, got asked to be chief of staff for a local hospital, which led then to a vice president of medical affairs. And I think, people ask me, why did you do that? I had no desire to do that, but I had the opportunity to listen to some of the directives given by our leadership at that time and thinking to myself that I had stories that needed to be heard from the patients that I meet with every day. We're great marketing tools as physicians. We are out in the community. We listen to patients, we listen to their barriers in health, and we listen to what we're doing well and what we're not doing well. And I realized as a physician, we needed to make sure we were being heard. Otherwise, we had no right not following the directives given to us by our leaders. We had to be part of the solution. Otherwise, solutions were made for us. And I think that's what motivated me to continue that journey in administration, be a vice president of medical affairs, which later gave me the opportunity to be president of one of our Ohio hospitals within Michigan, or within ProMedica, and then move back into Michigan. And it's exciting, but you need to find a new passion. So when you go from taking care of the immediate needs of a patient to going into administration, timelines are different. You get lost for a little bit, but you can still have that same passion you had with your individual patients. You just need to see the bigger picture. And it gives us the opportunity to break down some of those barriers that are in our communities that prohibit our patients from following the direction or the education we give them on what steps they need to do to live healthier lives. So we can meet with county commissioners or housing developments to make sure people have safe housing, have electricity. So that's how I took my journey, found my new passion, and haven't looked back ever since, and truly love it.
For our listeners, if you want to see an impressive resume, you need to see Dr. Yaroch's resume. It is an impressive journey, to say the least. So, Julie, you are a brand new chair of the MHA board, but you're joined by a record number of physician leaders now serving with you on the MHA Board of Trustees. And you alluded to it, but what's your sense of now being a CEO in a hospital and now leading the board from a clinical background? Do you think that your counterparts in the hospital setting and on the board, do they think about your leadership differently because of that clinical background, because of the expertise you bring to the table? How do you approach that as a physician leader?
Well, first off, really exciting to sit at that board meeting up on the island and see my fellow physicians. I was thrilled. I hope what I hear from those physicians that I work with within my own organization, and when I listen to them sell me to new providers that are joining the organization, I've walked the walk. I know what they've experienced. I can hopefully bridge gaps, break down communication barriers. So I hope when they see me in this position, they realize that maybe I bring a different sense of balance to the table. Numbers are important, finances are important, viability is important. But again, in healthcare, we can't always just build it and people will come. We have to really understand the patient population, the community, and the directives of the providers. Without providers, we don't have healthcare, right? Nurses, physicians, pharmacists. So I'm hoping when they sit around that table and see me in this leadership position, I may listen a little bit differently. But I also hope that I can lead by example, that when we sit around this table, I think you learned early on from me, we need to share our stories. We need to question, challenge. We need to, tell you if we don't think some of the initiatives or the direction is the right way, but give you reasons why. So I'm hoping I can inspire others to continue to take seats at MHA or AHA because it's important. We don't really understand that, I think, until we've been a part of it.
Well, thank you so much for that background, Julie. We are just a couple of weeks into the brand new MHA program year, and we'll talk about some of the challenges and the road ahead in just a moment. But before we do that, I thought it might be nice to reflect on the MHA program year that we just concluded. At our annual meeting, of course, we provided the results from our strategic action plan priorities. But can you just reflect on your sense of what were the most impactful accomplishments of the association, how that really sets us up for continued success in this new program year?
Yeah, so I just want to put a shout out to you, your leadership, and the MHA team. You guys are stellar. Listening to other organizations, different states, I am so impressed with what you do. You listen and you really fight for us. It takes a fight to care for community, so I appreciate everything this team does, and I'm really proud to be a part of it. So just looking back on some of the key initiatives that were accomplished over the past year, viability of hospitals is still forefront of mind. And I think, the Medicaid funding and what this team has accomplished and how we can maximize the provider tax program, stellar job. Mm-hmm. It's not unique to the state of Michigan, but from the time that you decided to take that direction to implementation is probably warp speed, and other states haven't been able to accomplish that. And what that's allowed us to do, at least personally speaking for us at ProMedica, is keep programs open. There are a lot of programs in healthcare that we need to do because the community needs access, but those programs, we lose money. We can barely stay afloat. And so these dollars allow us to keep those doors open and continue to service the needs of our community. Workforce, obviously the opposition to the mandated staff ratios comes to mind. But I also want to say, workforce is about some of the educational partnerships that you've started. So again, I've said we can't fix everything in healthcare. This really needs to be a team, a collaboration of other partnerships. And so when it comes to workforce, knowing where that next pipeline of talent is coming from is key for us. And really getting out there and making healthcare seem romantic again or seem as exciting as it has been for me is key to getting college students, high school students interested in going into this. So I think those educational partnerships that MHA started is a highlight for me as well. And then near and dear to me is public health. So I got asked to co-chair the public health task force. And that was initially brought up to look back at the pandemic and lessons learned and what we can do better and how we can get out the gate faster. But immediately it made me realize we don't all know what we're doing in healthcare. And there are so many organizations in this state that are doing great things, but we don't connect the dots always, and we don't collaborate probably to the best of our capabilities. And so this task force, I think, is finally getting us in the direction where we can bring the Department of Health, community mental health, hospitals together, listen, learn, understand each other's barriers, come with a unified message to come out to the public. So that one obviously has a special meaning to me.
Well, we appreciate your leadership of that public health task force. It's been incredibly important from my perspective in terms of setting the table for our future work. And we can talk a bit more about that. But you mentioned the nurse staffing ratio legislation, and that was clearly a major focus for the association in the last program year. And as you know, we're staring a lame duck session in the face at the end of this year where crazy things can happen. And so that's still very much an issue of concern. But just to spend just a moment on that particular topic, Julie, what would that nurse staffing ratio mandate mean for ProMedica? Give us a sense of how impactful that could potentially be for patient access to care.
I would say I would first say, what does that mean to my community? That would mean a change in access to healthcare. Because for us, it would put added restraints on us being nimble to flex to the demands that we see day in and day out. So I have nursing leadership that constantly looks at my bed management and determines where I need to move my staff so that I can care for what's coming through my emergency room and what's being seen in my OR to what's being discharged. So we have nursing leadership that has oversight on that. And being nimble allows us to react to crisis. And we have crises every day. You have motor vehicle accidents that you can't predict will come through your door, and you need to shift where you're putting your staff, or you could have delays in transition in care. So we look at that bed capacity management hourly. When you put a mandation like that, that restricts us from being nimble. And that means possibly closing units. And when I looked at that mandation, a good example is our critical care units. My critical care unit is very different at Hickman Hospital, which is only a 58-bed hospital, very different than a University of Michigan critical care unit. But those rules were the same, regardless of your bed size or your facility. And so I see a lower acuity in my critical care, so I don't need the same mandated ratio. But it was a one-size-fits-all, which in healthcare, that doesn't work for us. So it made it really rigid. And it would mean closure of units. It would mean added costs. It could mean service lines that are leaving our community.
Well, there's no question that you've articulated the concern of both our small rural members, our large urban systems, everyone in between. And at the end of the day, you're right, this really ought to be about access to quality care for patients, and that's where our concern really resides. But appreciate your continued engagement on that topic.
Yeah, and if I could add something, I think MHA has reported out statistics on the number of beds that we've lost just during the pandemic and the fact that we have a workforce shortage. So again, when you put mandated nurse ratios, you need more staff. And we just said workforce is still a concern. There is hundreds of thousands of nurses predicted to be behind from a workforce capacity management. We do not have enough nurses to fill the positions that we will have open in the next 5, 10 plus years. And so you have bed capacity. So what that also means to a patient that walks through our doors, they'll have longer stays in our emergency department. That could delay their care where minutes can make a difference. So I think too, when you look at the big picture, you could say, well, rural hospitals could be affected more, but if I don't have some place to transfer that care, it's a ripple effect throughout the entire state.
Well, that's a perfect segue as you're talking about the challenges in the months and years to come. Let's talk a bit now about the MHA program year that's just getting underway. When we were at the MHA annual meeting, Julie, just a couple weeks ago, your Friday morning inaugural address as the incoming chair was really terrific, and you articulated some of the things that you thought were critically important for us to prioritize. Can you just share a little bit about that, your perspective on this MHA program year that's just beginning?
So I think, the pillars don't change. Mental health was a hot topic for last year. Well, that needs to continue. There's so much that we need to still do on mental health. But part of what I stated in my speech was the partnerships that we need for mental health success. We need to bring the right people around the table, and those individuals need to own mental health for the state, for our community. So we, again, can't be responsible for all the solutions, but maybe we need to lead the conversations. Mental health, bring the Department of Health, bring community mental health, bring county commissioners, bring hospitals around a table and start addressing the obvious issues and barriers we have in front and come up with solutions, and then divide ownership of those solutions. So I think mental health comes top of mind for me as something that we need to continue. Workforce, we already mentioned, workforce isn't over. Again, partnerships. We need to start looking at partnerships with schools, getting into schools, talking with students. We were just talking about, a concern of mine is burnout of our current workforce. And people want work-life balance. I'm not going to say how many years I've been in healthcare, but, the days of having providers work 24 hours straight are going away. People want to go home. They want to be part of their kids' lives. They want to help their aging parents. And so I think we're going to have to look at how we bring new people into the workforce, but what shift work looks like, how many team members it's going to take to deliver care. And AI is not going to be a solution. We still need humans. That's why I love healthcare. AI can't replace us. And so I think when it comes to workforce, we're going to need to start looking at what's the new model going to be inside our four walls in the next 5 or 10 years. And we got to start prepping for that. And, I look at Europe. Europe has kind of come up with creative solutions that maybe we need to start looking at. How do we bring work-life balance? And then how many more additional workforce are going to need to be inside our four walls? What's the cost to delivering that care? Which then leads into viability. How are we going to sustain those solutions? Because as we already mentioned, bed capacity is a constant concern for me. Am I going to have somewhere to transfer patients when I need to transfer them? Am I going to have enough beds open? And a lot of times we can't open all of our beds because we don't have staff to staff those beds. So I think workforce, mental health is still a top priority. Viability, those Medicaid dollars needs to continue to be renewed, as you brought to our attention at the last board meeting. A lot of the efforts that you have, it's not a one and done. You need to continue to fight that fight each year. So I think those are still some of the top priorities.
Well, it really does make an incredibly significant difference to have the support from our elected officials in Lansing and in Washington, D.C. on issues like Medicaid payment, but also Medicare policy and all the rest. We talk about certificate of need. We talk about medical liability issues. The list goes on. We mentioned the fact that this is an election year and lame duck session soon to follow. So I'm wondering if you can reflect just a little bit on your perspective on the importance of engagement in that public policy and political advocacy domain, and really where you lean on the MHA to help with that whole process.
So this is the part that I would say I didn't really understand the importance of getting out in front of legislature until I was asked to join MHA and even AHA. Our role being in healthcare is to get out in front of legislature and educate them on what we see every day. We need, to break down the assumptions that are being made on our behalf of what we need and where dollars need to be spent. I feel we are the most knowledgeable subject matter experts to determine where dollars need to go, where program directions need to be navigated. So we need to get in front of local legislation, state, federal, and share that story and push back. We also need to, put invites out there to have those individuals come walk through our four walls, talk to our staff. We need to listen to them, and they need to listen to us. We need to come with solutions. So kind of like what I say to my team, I understand I'm not perfect. You need to identify gaps, opportunities we can do better, but you need to bring solutions because they know what they're dealing with on the front line better than I do. And then my goal is then to listen to them, understand their story, and share that at the state and federal level and help navigate where efforts need to be spent.
It seems that the whole concept of political engagement is front and center in society right now. And maybe that's partly a function of a very divisive environment and an election year where there's a presidential race at stake. There's always more attention paid. But we have a saying at MHA that politics is not a spectator sport. It's what you just alluded to. We really need to be directly involved, and anyone can do it. Hospital leadership, certainly, but clinicians, trustees, volunteers, anyone who has a stake in the healthcare arena should be engaged and should be studying the process, should understand who's running for office at the state and federal level. As the MHA has long done, we will again this year be supporting healthcare champions, both Democrats and Republicans alike, those who have demonstrated a commitment to do right by healthcare, by creating access to high-quality, affordable care for all 10 million Michiganders. And so I really do appreciate your willingness, Julie, to step up, and you've done a tremendous job of that, as you mentioned, working not only with us at the MHA, but also with the American Hospital Association as well. I imagine you've got a few trips to D.C. in store in the coming year. And maybe you can tell us a little bit about what that's like in terms of the action at the federal level as opposed to at the local level.
There's some similarities, some parallels that I think, obviously, when you are going on the Hill and talking with folks, the team size is a little bit different. The depth of understanding on healthcare is a little greater depth. But again, you have a very limited amount of time to tell your message and make an impact that's memorable, right? So it's a lot of meet and greets, sitting in lobbies, waiting for when you might have 3 minutes to get the attention of a staffer or someone, at the House or Senate or Congress. And it's being concise in your messaging, to the point, but also continuing that fight and sharing your passion. And hoping that you can kind of open a door that someone will follow back up with you, and it'll give you the opportunity to further explain your concerns or the opportunities that you feel we have to do even better in building healthier communities. Again, it's not where I'm comfortable. It's probably the one area that I feel most unsure about in my role. But again, I understand it because, again, you have given me the opportunity to sit down with folks, and I've realized how little knowledge they have or how one-sided sometimes that story is that they're hearing. And I do feel that most people in politics do want to listen. Will take the time. They may not agree with you, but that doesn't mean after your conversation they're not thinking about what you told them later on. And it could still affect how they're going to vote. And you got to keep repeating the message. I often find myself saying the same thing over and over again, but if they can get one more takeaway that can help us in healthcare deliver the mission that we have, then that's a win. It's baby steps.
Well, you've pointed out the importance of political advocacy, but I think in your comments today, you've also lifted up the potential role of the association as a convener and a thought leader, meaning on those emerging care delivery and financing models, emerging technology, whatever the case may be, we can help to identify best practices and bring folks together for shared learning purposes. And I suspect we'll be doing a lot of that work that doesn't necessarily involve passing a new law, right? It really involves collaborating and doing what we have done so successfully for 25 years now with the MHA Keystone Center. But back to some of the issues, Julie, that you are lifting up for this year ahead. And you mentioned the challenge of workforce, the challenge of mental health. I want to reflect on an issue that was the topic of a pretty robust discussion at the MHA board meeting just a couple of weeks ago that I suspect will be on our radar screen in a big way in this program year ahead, and that's the issue of cybersecurity. And we've seen a lot of cyber attack activity here in the United States and certainly right here in Michigan in terms of our own members being directly impacted. What does that look like from your perspective as a hospital and health system leader who's caring for patients every day? What about cybersecurity keeps you up at night?
So this is where, I'm so grateful to have a really robust team. So, when I talked with my cybersecurity experts, it's probably the number 5 risk for us as an organization. And it touches everything. It's not just about an attacker getting into your medical records. With the increasing number of AI that we use in technology, delivery of care, you could break into our robotics and abstract information from that piece of equipment. So, as we get more and more advanced in healthcare, that cyber threat becomes a greater reality. The other piece too is it really shuts down your best practice. We rely so much on putting everything in electronically. And when you have a cyber threat, you shut down everything and you go to paper charts. And that's not how this generation works, right? So it can pause your reaction and how you deliver care, but it also delays our timeliness in getting patients discharged and freeing up that bed for those folks that are sitting down in our emergency department. So it affects our operations in multiple ways. And it has a trickle-down effect, not just at hospitals, but your private providers. A recent cyber threat that people are familiar with Change. I had many private providers that said they had to retire early because of the delay in getting paid on some of their billings and their charges, their accounts, outstanding accounts, and that caused them to close their doors. And so I'm losing providers in areas that I'm a desert. I need those OBs, and without them now, people are driving further. So it's not just, big systems, it's those independent providers that probably are more impacted more so than I am. But when you look at cyber threats, I talked to my team, we have about 1,000 events per week that put in a ticket to raise concerns that this could be a breach of all the walls that we put in place to try to protect us. And then through AI, we can scrub a large portion of those, but about 300 to 400 of those a week, we need to have a team go in and do a deeper dive. That's a lot of manpower. That's an added expense that we didn't have, 10 years ago. And just with our vulnerability and the collaboration we need to do with outside services to measure our performance, again, those are added costs that we need to put in place, rightfully so, to protect our patients, protect our staff, that take away from the innovation that we want to do to deliver care at the bedside.
The concern would be that the FBI, once again this year, has lifted up healthcare as the number 1 target globally for cyber criminals because of the richness of the data that we house. We have a target on our back, and I think that's been evidenced by the events of the last few months. And certainly we need to be vigilant, but once an attack occurs, as you know, we need to work with law enforcement, but we also need to work with the mitigation experts who can get us back online as quickly as possible in terms of delivering care unimpeded. And certainly working with the payer community, whether that's Medicare and Medicaid, but also the private insurer community as well, to make sure that they can be flexible in terms of their processes to allow the trains to continue running on time from a financial perspective. I think that's critically important as well. So these are all issues that will certainly be topics of much discussion at the MHA in the year ahead under your leadership. Well, Julie, it's always fun to hear a bit more from an individual hospital or health system leader such as yourself about what's happening at the local level. And what activity you'd really like to shine a light on in terms of what's happening at ProMedica these days, maybe some issues that we haven't touched on yet.
Yeah, so, I think we have really made some changes or pivoted in our organization, and that's allowed us to really focus on our core operations, so hospitals and outpatient providers. And one thing we don't talk about a lot at MHA that still is forefront for all of us is quality and safety. Yes, you need to make sure that the dollars match and cybersecurity is a threat, but quality and safety is something that needs to be at the forefront each and every day. So, one thing I'm really proud of is how we have changed how we look at quality and safety measures. And I talked about it's a team that takes care of a community. And we've realized as it relates to quality and safety, we have to have the right players around the table. And we haven't probably always had that in the past. Everything from your IT folks down to your frontline staff need to have a voice on their concerns and what they are seeing on areas that we can improve. And one thing I always challenge my team, we can always do better, but we need the team to share in that direction that we're going to take to have better outcomes. So I'm really proud with some of the initiatives that we are taking to hit those quality metrics and those safety metrics that we put in front of us. AI is always an interesting topic now in healthcare. We have a very robust team related to robotic care. And robotics isn't just about being fancy in how we deliver care, smaller incisions, but that also affects or parallels our safety initiatives. We know with robotics, we have a decreased length of stay. We have better pain management. So patient satisfaction is better with robotic surgery, decreased infection rate. So a lot of that technology parallels, again, with quality and safety and best practice. And then workforce. We are bringing in a robust team that's getting out there and talking with students at the front line, grade school even, explaining to people it's not just nurses and doctors, it's phlebotomists. You don't have to be the smartest kid in the class to be in healthcare. And I think there's a lot of positions in healthcare that students don't realize, IT being one of them, facilities, environmental services, dietary, those are all important people that impact our delivery and care. And so we're really trying to get back out there and reinvigorate healthcare. People got scared, I think, with the pandemic.
Right.
They shied away. I do think sometimes it's the safest environment because we have all of these policies in place related to masking, related to gloving, related to airflow. So we're minimizing the risk to our staff and to our patients of contracting new diseases when they sit in their four walls. Does it still happen? Yes. But it's probably safer than most places, most work environments. So again, telling that story, saying, yes, we're safe. Yes, there's opportunities. A lot of us, if people have the ambition to go in healthcare, they have great communication, people skills. We can't teach that. We're willing to educate them, help them, train, mentor them. You could start as a phlebotomist. And I think many of us are saying, if you want to be a nurse, we're going to help you with that journey. So we're starting to look at creative ways that we can be that pipeline for that next generation.
You've said it really well, Julie. And as you know, for many years, the MHA has lifted up the fact that healthcare is actually the largest employment sector in the state of Michigan. And it's likely to continue on that track based on the aging population, the demand for healthcare only increasing into the future. And I'd be remiss if I didn't mention our relatively new MichiganHospitalCareers.com campaign. The MIHospitalCareers.com website is live. It has been a wonderful resource for folks who are considering healthcare as a career option for all the reasons that you just lifted up. And I imagine that'll continue to be a major focus for us in the year ahead. I want to go back to something you mentioned, though, just before talking about workforce, and that's the quality and safety issue. And it strikes me that one of the mega trends that's impacting healthcare going forward, both here in Michigan and nationally as well, is this push towards greater transparency. And we see bipartisan support in Congress, for example. We see administrations at the federal level in terms of policy coming from the White House that really prioritize greater transparency, both in terms of pricing, but also quality. And then there's all sorts of private sector organizations that are into that space in an increasing way also. And it seems to me like that greater thrust towards transparency toward the public really amplifies the need to be doing all we can to maximize quality and safety, because there's going to be a very bright spotlight that's shining on the outcomes that we're producing, right?
Yeah, and I'd like to say on the topic of transparency, it's difficult in healthcare because every patient is unique. So this is where healthcare differs from, let's say, the automotive industry, where I do believe that every piece of equipment that goes into the car is the same piece of equipment and should operate the same way and should react to road conditions the same way. Every patient that walks through our doors is unique. And so when you come in for heart failure, we may also have diabetes, and that adds an added level of severity or complexity. You may also have a low blood count. So that transparency is a struggle for us because each patient is unique. They have a different set of problems that we have to address. And so it is something that I think that will be a constant battle between what's being asked from us at the federal level and what we can actually deliver on. But I think we're trying to get there. I think those quality metrics that you alluded to are key on some of our financial performance. You know, when I look at maternal health care and how can we improve maternal fetal outcomes, and there's been a lot of discussion around added dollars given for those hospitals that follow best practice and have better outcomes. I think that makes sense to assign those dollars to outcomes. I think putting rigid policies around how you deliver that care can be restrictive because we all have different barriers in front of us. And it's not cookie cutter. That's why I love medicine. There is not a game plan that I follow strategically play by play. I have to constantly pivot. So I think looking more so at tying dollars to outcomes could be an opportunity that could be a win for both of us, both on the legislature side and on the healthcare side.
Well, as you're talking about that phenomenon, it really strikes me that there's a parallel. If you look back in time when the federal government implemented the Medicare payment reform related to readmissions penalties, and what the conversation really entailed at that time, as you recall, is that much of the readmission activity that was occurring and continues to occur is outside of the hospital's direct control, and it gets to the issues you lifted up earlier in the conversation around health equity and public health. It's those things that get in the way of appropriate follow-up care, whether that's lack of transportation to get to follow-up appointments, whether it's the lack of appropriate housing. Some folks don't have a refrigerator to store a medication that needs to be refrigerated, right? It's something that simple. But we were being penalized when folks would be readmitted to the hospital within that prescribed window. And so, you know, that's just a snapshot in time. But I think what you're lifting up here is really the fact that we have to, you've used the word partnership, we have to partner with non-traditional allies in the community to really get where we need to be in terms of maximizing patient outcomes, right? It's not all about what happens inside the four walls of the hospital.
Length of stay, if you ask me, you know, what's a topic that occurs, you know, at the federal level, you know, length of stay is something as a provider that I have continuous concerns over. You know, the length of stay for what we're allowed to treat a patient for keeps getting shorter and shorter. And you alluded to all those outside factors. You know, when someone walks in my four walls, I always tell people I don't look at what type of insurance they have. We accept everyone who walks inside our four walls. And if they meet qualifications that require them to be in one of my beds, we're going to put them in a bed and we're going to fight to find a bed. That journey, though, also makes us responsible to make sure that when we discharge a patient, we're discharging them to a safe environment. We're discharging them to an environment that they can continue the care they need post-discharge. No one leaves our beds and are perfectly healthy. Like you alluded to, you need a refrigerator to make sure you can put your insulin in that. You need to make sure you have electricity so you can do your nebulizer treatments or use your CPAP. you need to be able to have transportation so you can get back in for those follow-up treatments for your IV antibiotics or your chemotherapy. And those outside barriers, I don't have control of. I need to be a voice at the table to try to find solutions for that and speak up on behalf of my patients. But it takes a village to come up with those solutions. And those barriers are real barriers that affect our ability to follow those length of stay mandations. Or like you alluded to, those readmissions. A lot of times when I look at readmission rates, it's because a patient couldn't afford to fill their medication. And so, they don't fill their medication, they come back. Or their family members no longer live in town, so they couldn't get transportation to get in. I have a high geriatric population. Many of them don't feel safe to drive at night. And so, when your days get shorter, people don't follow up. They do no-shows, and that can affect their overall health and bring them back into our emergency room. So those partnerships, telling those stories to our payers to say, look, you're very rigid on what you will pay for, but there are so many outside factors we don't have control over, but we need to be responsible that those factors are addressed. We can't turn a blind eye. My team's passionate that everybody is going home in a safe environment. That can add to that length of stay, and that changes our reimbursement model. You mentioned the readmission rates. That changes our reimbursement model as well. And the payers have responsibility in this too. More and more times for that transition of care. So when someone's in one of our inpatient beds and they need to maybe go to a long-term care facility, we need to get prior authorizations. And sometimes those prior authorizations can take days. And that changes how many days your patient is sitting in a bed. And I still have to pay my staff for those additional days that the patient may be sitting there, but I can't boot them out, nor am I going to boot them out of my beds. So there's a lot of factors that go into play on us being able to meet those requirements that are just requirements for hospitals. And I think we really need to look at that. And this is where I challenge providers who have significant concerns that it's starting to get dangerous. Not all knee surgeries can be done as an outpatient. Not all hip surgeries can, particularly when you have patients that have comorbid conditions. So they could have diabetes, heart failure, or they live alone. And a lot of times we get denied those hospital short stays, but we're doing it because it's the right thing for the patient to have safe care. And that's our goal. That's our responsibility, is to the patient. It's not to the payer, but we often eat those costs.
Well, Julie, as you know, one of the consistent priorities for the MHA over the years has been the 340B drug pricing program. And we have been involved, certainly in terms of our advocacy with Congress, more recently in the courts, where we were an amicus party to a lawsuit that, in fact, was mitigated by the Supreme Court of the United States. In fact, they ruled unanimously in our favor. You don't see that happen very often. And now, even in the last year, we've been advocating for 340B at the state level here with our State House and Senate. So a very, very important and impactful issue. And I know you have a pharmacy background with responsibility over pharmacy before you came into your current role. So I would love to hear your thoughts on the importance of the 340B program.
So first off, 340B is a very confusing topic. So I am really grateful of the amazing team that I have that have been really patient and helped educate me. But as you alluded to, it's a hot topic both at the state and the federal level. I think that's where I've been asked to speak more frequently than any other topic. 340B, as you alluded to, is a drug pricing program. It really is a cost avoidance for those facilities that qualify under 340B and allows us to have additional dollars that we can put into community-based care. What I think a lot of people don't understand is there are specific qualifications that were placed in front of us by the federal government in order to be a 340B participant. And we have to meet those metrics. We have to show that we're meeting those metrics, I think, twice a year. And if not, we fall out. I have a hospital that specifically once was a 340B, and we lost that 340B status. And the impact is significant on us. Not all drugs fall under 340B. There are certain drugs, and as we know with some of the fights that are being done with some of the pharmacy companies, more and more manufacturers are pulling drugs off of that 340B eligible list. And that's huge to us because these are drugs that we use for oncology, rheumatology, gastroenterology. These are high-priced drugs that as we see the payer reimbursement go down, we often struggle just breaking even on delivering this care. But this care has outcomes that we haven't been able to deliver, 1 year, 2 year, 5, 10 years ago. These are patients that typically we've tried lower cost care and they've failed. They haven't responded to that therapy. So losing this program means we probably will not have the same access or treatment plans to a large sector of patients that we see day in and day out. And that's going to affect our outcomes. And when you have poorer outcomes, when you look at the ripple effect to the economy of your community, that's going to put a greater stress on disability insurance. To mention, we're going to have less workforce because people aren't going to go back to work because they're not going to be able to show up for their job because of their pain or the disease pathway that they've taken. So those 340B programs allow us to get drugs that we need to treat patients, to keep them healthy, to have the best quality of life that they can. It also keeps programs viable inside our four walls, keeps services open, and allows us to support against community-based care, community benefit programs like those social determinants that we talked about earlier.
Well, Julie, this has been an absolutely fascinating and entertaining discussion, but you've lifted up a number of really important issues for us for the year ahead. Before we close the conversation, I wanted to give you the last word. Are there any other topics, issues, concerns that really come to mind that we haven't discussed yet?
We talked about health equity, social determinants of health. I obviously have a huge passion for that. My organization has been a big supporter of food insecurities, food deserts. My local community has a sector that has a high social vulnerable index. And, we're looking at what we can do to kind of form partnerships related to financial stability, making sure people have safe housing. I encourage folks that if you have concerns, you have a voice that needs to be heard, that you need to make sure that you're getting around a seat at the table and you're making sure your voice is heard. So that would be my parting statement is, again, hospitals don't have all the solutions. We can't be the one to carry out all the directives, but we can bring people to the table, encourage them to talk, encourage them to build healthier communities. I believe you had a speaker once that said policy is medicine. We all need to be a part of those policies and make sure they fit our infrastructure. And we all have the same common goal. We all want to have healthy communities, and I do think we can achieve that goal, but we got a lot of steps in front of us.
Well, we appreciate your willingness to lead in that journey. You've been listening to the MiCare Champion Cast and the new chair of the MHA Board of Trustees, Dr. Julie Yaroch. Julie, thank you again. It's been a real pleasure to have you today. We appreciate it.
Yeah, thank you for having me.